Welcome guys to this lecture in which we will discuss about the previous question of the DNB General Medicine paper. Okay, so we are going to discuss this question. It was asked in basically December 2017 paper about sick euthyroid syndrome to write this diagnosis and treatment and amiodarone induced thyroiditis. So in this video we will discuss about the different effect of amiodarone on thyroid function, and this lecture will be solely based on the Harrison new edition. Okay. So to start, first question that we need to know is what is amiodarone. Alright, what is amiodarone? Amiodarone is a broad spectrum activity of antiarrhythmic agent. Alright, it is a broad spectrum antiarrhythmic agent and mainly it belongs to the class 3 of antiarrhythmic drugs, but it affects both myocardial depolarization as well as repolarization in addition to its principal effect on class 3, which is what is class 3? Class 3 is basically the potassium channel blocking action. Alright. So beside class 3, it also has effect on other cells antiarrhythmic effect, that is class 1. Class 1 is sodium channel blocking action, then class 2 which is beta blocking action, and class 4 which is calcium channel blocking. So you can see it has got very wide range of activity and can be used in lot of different types of arrhythmia. Now it is the most commonly used antiarrhythmic drugs worldwide, and it is why it is most commonly used. It is effective in treatment of both supraventricular as well as ventricular tachyarrhythmia and has the advantage of being all tolerated in patients with low systolic volume also. That is normal systolic function as well as low systolic function, we can use amiodarone with ease. Okay, so that's why it is used worldwide. Now issue with this amiodarone is that it is structurally related to thyroid hormone. Alright, it is structurally related to the thyroid hormone, and that's why it has got a lot of to do with effect with the thyroid metabolism and function of thyroid in the body. Alright. Now coming to the structure, we will just discuss about very basic thing. This above one are the two thyroid hormones of our body, thyroxine and T3, that is triiodothyronine. Basic structure is, you can see there is two phenyl ring. This is basically a tyrosine ring. Okay, there is tyrosine ring. There is same also tyrosine, one tyrosine moiety and a phenyl moiety. So this is the basic ring form structure of the thyroid hormone, and it contains the iodine moiety attached. In thyroxine, as the name suggests, it has got 1, 2, 3 and 4 iodine molecule, whereas in triiodothyronine there is 3 iodine molecule. Similar to this, you can see the structure of this part. This is amiodarone molecule structure. It has also got a benzene ring, and this part is benzofuran, where benzofuran furan group is represented by the butyl group. So this is a benzofuran, and the iodine moiety is attached. Iodine moiety is attached here. Okay, this is one iodine moiety, this is another iodine moiety. Now due to this structural similarity, it has a lot to do with the effects and function of the thyroid hormone. Now beside this benzene ring, we know aromatic compound. Benzene ring is the aromatic property, and aromatic compound are lipophilic. That's why they passes the membrane easily and gets deposited in the thyroid tissue as well as in the other body tissues. Alright, okay. This is the little bit of chemistry about this thyroid hormone similarity and amiodarone similarity. Alright. Now, what is the daily iodine requirement of the body? If we check the daily iodine requirement, we need only in normal adult population, we need around 150 microgram per day. Now it is felt that although 150 microgram is daily requirement, up to 1 milligram per day is safe limit. Alright, is safe limit. And more than 1.1 milligram per day ingestion is associated with harmful activity that lead to acute or chronic toxicity. Okay, that's all we have discussed till now. We have discussed about the amiodarone and thyroid structure similarity, the iodine requirement of the body, and the toxic range. Now, what happens is that where is the issue is that if you check the amiodarone, the dosage, which is used mainly in lot of cases, lot of cardiac arrhythmia related cases, as in case of ventricular arrhythmia. It is also used off-label in pulses, ventricular tachycardia or ventricular fibrillation. It is also used in SVT, supraventricular tachycardia, as well as AFib, and it is most commonly in cases of AFib in most of the intensive care units. Alright. So dosage of amiodarone is initially we give 150 milligram as a stat dose, that is a bolus dose. So 150 milligram is bolus dose, followed by initial dose of 360 milligram in 6 hours, followed by 540 milligrams in 18 hours, and 720 milligram of maintenance dose of in 24 hours. Okay, so this is the dosage of infusion in case of acute arrhythmogenic event of amiodarone. Now you can see literally this is a very high dose, and if after maintenance we need to convert to oral tablet, the usual dosage of amiodarone is around 200 milligram tablets, that is 200 milligram tablet forms twice daily, that is BD dosage initially for 2 to 3 weeks, followed by OD dose. Okay, so what comes in issue is that we know the iodine requirement of our body is around only 150 microgram per day. That's enough for our body to meet our needs, and more than 1 milligram goes into the toxic range, which causes acute or chronic complication. Now amiodarone, which is the smallest amount of dose we can, if we consider, is 200 milligram OD. Alright, 200 milligram once a day dosage is the smallest amount of dose that can be prescribed. Now among of this 200 milligram, around 30 to 40%, 37 to 40% is the iodine. So around 80 milligram is the iodine that a person consumes with one tablet of amiodarone, which is around 40 to 50 times more than the daily requirement of the body, and enough to cause a toxic imbalance in our body. And also owing to this its high lipophilic nature, this amiodarone gets stored into the body, into the different tissues, into different fatty tissues for even 6 months after stopping the drugs. So if amiodarone tablet is stopped, its effect on thyroid can be seen even after 6 months. Alright, that's the main issue and the nitty-gritty of the complication of amiodarone. Now coming to the detail, like what are the issues that is used with this, that amiodarone, what does it do? It increases the, first of all, iodine level. This iodine itself inhibits the deiodinase enzyme. Deiodinase enzyme inhibits deiodinase enzyme, which was responsible for peripheral conversion of T4 to 3. As a result, what happened? As a result, peripherally T4 level rises. T4 level rises and free T3 decreases. Free T3 decreases. And TSH also gets lowered. Okay. So this is the case of euthyroid hypothyroxemia that is seen. Secondly, amiodarone itself is a weak antagonist. Of thyroid hormone action. Okay. Alright. This is the main modes in which amiodarone causes the thyroid dysfunction in our body. Now, coming to little bit deal, what will be the effect in our body for it? So we know what is amiodarone causing. Amiodarone causing is inhibiting the deiodinase enzyme, increasing peripheral T4 level, decreasing T3 level. This in turn, you know T3 is the most active form. T4 is almost like storage form in our body. Alright. So T3 is the hormone which shows our action. So T3 circulating T3 amount is low in our body due to the amiodarone effect, but T4 is increasing, which leads to state known as euthyroid hyperthyroxemia. Alright, euthyroid hyperthyroxemia. Also, as circulating level of T3 is low, there is increased requirement. If a person is on levothyroxine tablet form, there is increased requirement of levothyroxine in a patient on amiodarone. Okay, because we need to give more T3 supplies. Now the effects, if you look properly, there are two type of effects that is done in your body due to this iodine effect. Okay, so due to the high iodine load, it can lead to the effect which is known as Wolff-Chaikoff effect. It is usually seen in patient who has pre-existing conditions like Graves' disease or thyroiditis. Basically, it is a autoregulatory phenomena in which, due to the increased circulatory load of the iodine, thyroid itself stops synthesizing more of the hormone and prevents the release of the thyroid hormone in the bloodstream. Okay, so initially, if a person is started on amiodarone, body's response is Wolff-Chaikoff effect due to the increased iodine content in the bloodstream, which prevents the thyroid gland to synthesize more thyroid hormone and to release in the blood. So resulting in what are the biochemical parameter change we can see? We can see that T4 level will increase as T4 to T3 conversion is decreasing. T3 will become low, and in response to this, TSH will increase. Now this is the initial effect, but after sometimes Wolff-Chaikoff effect is passed away and body develops an escape phenomenon to it. Alright. Okay. Nextly, there can be Jod-Bezdos effect due to circulatory iodine content, which can present as thyrotoxicosis. Alright, which can present in thyrotoxicosis. Okay. Now coming to other manifestation of autoimmune thyrotoxicosis. So this amiodarone induced thyrotoxicosis can present into two types: type 1 and type 2. Alright. Type 1 invariably presents with a condition in which there is underlying thyroid abnormality. For example, in case of preclinical Graves' disease or nodular goiter, it is seen. And type 1 is mainly due to the Jod-Bezdos effect. In type 2, instead of the iodine content, type 2 is mainly associated with the direct effect of the amiodarone, which causes drug-induced lymphocyte activation, resulting into histiocyte accumulation in thyroid gland. So what happens here? What happens? Due to the accumulation of thyroid and damage of the thyroid, a huge amount of thyroid is released in the body, but apparently after that thyroid becomes non-functional and resulting into in the later stage hypothyroidism. So initially presentation will be with the thyrotoxicosis, and in milder variety patient will end up into hypothyroidism in long run. Okay. And person with abnormal thyroid gland profile, as in preclinical grapes or nodular goiter cases, due to increased supply of the iodine, thyroid production rampantly increases, resulting in the type 1 variety of the amiodarone induced thyrotoxicity. Now, how to differentiate? It is very much essential to differentiate between type 1 and type 2 because management differs. Okay. So if we check the color Doppler, of the thyroid gland, as activity is increasing in the type 1 because of the increase in the iodine content, obviously there will be increased vascularity. In type 2 variety in color Doppler, what you will find in color Doppler, as histocyte accumulation is leading to the damage of the thyroid gland, therefore in this case there will be decreased vascularity. Alright, obviously blood supply will decrease in the type 2 variety. Now, what is the role of thyroid nuclear scan? Thyroid nuclear scan usually has very low value in detection of amiodarone induced thyrotoxicity because due to the increase in the iodine content in the body, there is decreased uptake of the tracer molecule. Alright, but still some clue can be achieved from nuclear scan in the form that if there is normal or increased uptake, invariably it means it is type 1. Whereas as type 2 gland itself is getting destroyed, there will be nuclear scan, there will be decreased uptake. Usually there is decreased uptake due to the iodine content. Okay. So management, coming to the management part, it is very much simple. Is first of all, in any case, go for stoppage of the offending medication, that is, stop the amiodarone. But what is practical concern regarding stoppage of amiodarone? We have already seen amiodarone is initiated in a patient with ventricular arrhythmia, pulseless BT, alright, or tachyarrhythmias, and there is a lot of widespread cardiovascular complication associated with it. If you go to stop amiodarone suddenly, it may even kill the patient. That's why it is very much tough in practicality. Also, if we have already seen amiodarone, because of lipophilic nature, is stored in the body form, in the lipid form, for more than 6 months even after stoppage. Okay, so acute stoppage of the offending medication will not prevent any symptom. There may be symptoms still develop and it may continue to rise even after stopping the drugs. Okay, so next thing is that which can be tried is high dose of antithyroid medication. Now, high dose of antithyroid medication is more beneficial in case of type 1 than type 2. Why it is more beneficial in type 1 and type 2? Obviously, in type 1 AIT, the main pathophysiology is increased production. Therefore, we give antithyroid in high dose of antithyroid to counteract the action of the thyroid hormone. Alright. Whereas in type 2, what is the main pathophysiology? There is the damage of the thyroid gland resulting in the release of thyroid hormone. There is inflammation, accumulation of histiocytes. Therefore, main treatment option is to give membrane stabilizing effects and anti-inflammatory effects like steroids in type 2. Alright? Okay. There are also some rules which suggest to give iodine lowering medication. Alright, so if we check type 1 AIT versus type 2 AIT, what is mean pathophysiology? Mean pathophysiology is increase in the iodine level. Here is damage to thyroid gland by direct effect of amiodarone. So as there is increase in iodine level, we can give a thyroid iodide binder like potassium, percolate. Alright, we can, as iodine level is increasing, it is causing by George-Bastos effect increased production of thyroid hormone, so we can give anti-thyroid medication. In type 2 there is damage because of inflammation, so we can give anti-inflammatory, that is steroid. Okay, so this is the potassium perchlorate which is used in type 1 amiodarone induced thyrotoxicosis. Its dosage ranges around 200 mg QID. It is nothing but a thyroid iodide binder and resulting into decreased circulatory content of the iodine level. Okay, so issue whenever you use potassium perchlorate is you need to keep in mind that patient may land up into agranulocytosis. Although it is not seen in the acute usage, it is seen in the long-term usage of potassium perchlorate, but still there is a risk of agranulocytosis. Okay. Then nextly, what is this? What we need to keep in mind is, okay, this is once again the type 1 and type 2 of amiodarone induced thyrotoxicosis. So it is seen in pre-existing thyroid disease. Yes, pre-existing thyroid disease like grapes or subclinical grapes or multinodular goiter or thyroiditis, it is seen. Ultrasound, obviously ultrasound is another modality that we didn't discuss yet. Ultrasound can help you to differentiate between type 1 and type 2 because in type 1 goiter can be identified with ultrasound. Even also clinical examination you may find goiter which will suggest more of the type 1 variety. Now Doppler, we have already seen there is increased vascularity whereas decreased in type 2 because of the destruction of the tissue. Radionuclide iodine scan, they will be normal or elevated, and obviously it will be very low in type 2. Thyroid autoantibodies, because we are speaking about subclinical grapes or multinodular goiter or pre-existing diseases, so thyroid autoantibodies may be present in case of type 1 AIT, which is usually absent in type 2, and response to steroid is seen in type 2 AIT. Okay, alright. So this is the radionuclide scan which shows increased uptake. So increased uptake is usually seen in the type 1 amiodarone induced thyrotoxicosis. Okay. So this is the management we have discussed already. Amiodarone induced thyrotoxicosis suspected. First step is the discontinuation of the amiodarone. Now second is divide based on the clinical feature and the history, whether it was AIT type 1 or type 2, what are the features suggestive of AIT type 1. In clinical examination, you may find goiter. And symptom of type 2, besides thyrotoxicosis, will be widespread inflammatory symptoms in type 2. Alright. Usual presentation of thyrotoxicosis will be there, that is warm hands, sweating, weight loss, unintentional weight loss. Everything will be associated with it, along with multiple episodes of loose stool, vomiting, weakness. Everything will be there, and warm and sweating will be there. Warmness of the touch, on touch the patient will be warm. Breathing features of thyrotoxicosis will be always there. Along with if you see multiple episodes of fever, running, continuous fever, and source is not yet identified, it suggests more towards type 2 rather than type 1. In an examination, if you find goiter, it suggests more of a type 1. Now, if it is type 1, first step was discontinue amiodarone, and to start antithyroid. Antithyroid methimazole can be started as well as propyl thyroxine can also be started. Carbimazole can also be started. Propyl thyroxine initial doses 100 milligram TDS to start with, and potassium perchlorate can also be started, which is 200 mg QID. Issue with perchlorate is it is associated with agranulocytosis, which is same issue with methimazole or carbimazole groups. Alright, it can also lead to agranulocytosis. Okay. Now next step is check whether repeat the thyroid samples, thyroid profile, and check for the status. If there is euthyroid state is achieved, gradually taper the propyl thyrosol dosage over 2 or 3 weeks to 50 milligram twice daily. Alright, and continue to monitor the patient. Alright, and if there is no improvement, you can think that, okay, we'll come to this picture. You can think that it is a mixed variety. Alright, so we will treat also like AIT type 2. So in AIT type 2, but because of the inflammation, we started glucocorticoid. Glucocorticoid usually in the range of prednisolone is preferred, and dosage ranges from 30 to 50 milligram once a day for initial doses. Now, if euthyroid status is achieved, gradually taper the drug, taper steroid dosage, and continue to monitor the patient. Now, if there is no improvement, even after steroid, even in this limb, if there is no improvement after steroid, next step is thyroidectomy, which is the last step. If you remove the thyroid, you need to supplement with levothyroxine. Sometimes there are issues you cannot discontinue amiodarone. There is life risks because of the arrhythmia. That time, thyroidectomy becomes the first choice rather than other medication, and to supplement the patient with levothyroxine for life. Okay, so I think my friend, it is clear.